Okay, online folks, can you give me a hi if you can see our slides and hear me right now? Perfect, thank you. All right, we're going to get started with our next speaker. Dr. Michelle Rose is one of our 3 board-certified cardiologists, along with Dr. Rima Carbush and Robbie George. And I love it when she speaks because she's a great teacher.
Oh, thank you so much, Heidi. Good morning, good almost afternoon, and hi everybody who's here live. Nice to be here. So we're going to talk about Rapamycin today, a new medication for hypertrophic cardiomyopathy in cats. There we go. Okay. So first we'll discuss a brief review of hypertrophic cardiomyopathy, followed by our actual topic of the day, rapamycin. And there's been one major trial that has evaluated rapamycin in cats thus far called the RapaCat trial, which was published back in July of 2023. Then we'll discuss the current newly started and back in fall of 2024 trial, the HALT trial. So that one is underway. And then we'll discuss how rapamycin has received conditional approval from the FDA for use in cats with subclinical HCM. So that's very novel in my career. I can't remember another drug that's ever received conditional approval for cats with heart disease. So this is exciting stuff, followed by some future studies and future directions in the use of this drug in both cats and dogs. So hypertrophic cardiomyopathy, I think we're all familiar with it. So it's a primary heart disorder. So this does not occur secondary to something else. It's an inherited genetic disorder of the heart muscle, and it's characterized by concentric hypertrophy. So that means that our heart walls are growing inward into the chamber, not eccentric dilation where the overall heart is getting bigger, as shown like a silhouette on radiographs. This is a normal sized heart where the walls are growing inward. Typically, 90% of the time, this is just a left-sided heart disease. 10% of the time, it is biventricular, so the left and the right ventricle being affected. HCM does occur in the absence of other causative factors. So before we can say a cat has HCM, of course, we're going to want to rule out hyperthyroidism because that will also cause concentric hypertrophy that is most often reversible in cats. We want to rule out systemic hypertension. And then lastly, infiltrative disease. So lymphoma would be a type of infiltrative disease that thickens the myocardium. So would myocarditis. And I should also mention acromegaly, an endocrine disorder, can also cause hypertrophy of the left ventricle. Okay, so that being said, we're going to get to our first interactive slide here. So you guys can go ahead and scan the code. How often do you suspect or at least diagnose HCM in your practice? Either one's fine, suspect or diagnose. Do you do it once yearly, once quarterly, monthly, every other week, every week, or almost daily? For me, I'm admittedly daily, but I'm kind of biased. So I'm curious to see what everyone says. We have 8. I'll give a few more seconds for people to respond. Interesting. That's enough time, you think? Okay. All right. Very interesting. So about half of you once a year. A quarter of you is once a quarter. 18% once monthly, 9% once weekly. Wow, and nobody saying every other week or every day. Okay, very fascinating. Thank you for that. Okay, so HCM, I was taught it had an age of onset of 6 months at the absolute youngest. So most cats are well over a year when they're diagnosed, and they can be very, very old, all the way up to 18 years. But we do see juvenile onset HCM. And so I was taught it could occur as early as 6 months of age. But now I've had 2 cats in the last 3 months that have had it at 4 months of age. And unfortunately, it was really severe in these kittens. So I'm going to change that myself and to say 4 months to 18 years. So humans, we've had, or not we, but they have identified about 1,000 genetic mutations that can cause HCM. So it's very multifactorial. In cats, we've identified 3 genetic mutations so far. So one in the Maine Coon, the myosin binding protein C gene. Same gene, different part of the gene in the ragdoll, the myosin binding C for the ragdolls as well. And then new in the Sphinx, they've identified an ALMS1 protein genetic mutation. So now we have 3 different breeds that we can test for HCM. And if they have the gene, then we know they're more predisposed to get the disease, but we for sure have not found all of the genetic mutations responsible for feline HCM. So the reason I asked how commonly do you diagnose this in your practice? In humans, this is a relatively uncommon heart disease. So only 1 in 500 humans will get HCM in their lifetime. But in cats, it's actually about 14.7% or 1 in 7. So theoretically, in a perfect world, if you were seeing 7 cats a day in your practice, 1 of them probably has HCM. It's very difficult to diagnose, as we all know. So cats don't come in with a sign on their chest saying, "Hi, I have HCM." So it's quite a challenging heart disease to diagnose because most cats with HCM don't have a murmur, don't have an arrhythmia, and don't have a gallop that we can auscultate with our stethoscope. And then further complicating that, if we do have a cat who has a heart murmur, of course, there are benign causes of heart murmurs. So about 2/3 of heart murmurs in cats are benign. So it doesn't mean that the cat has HCM. So it is complicated. And if we take thoracic radiographs looking for cardiomegaly, almost all cats with mild and moderate HCM are going to have pretty normal looking thoracic radiographs because again, their cardiac silhouette is not dilating. The walls are growing inward. And it's really, really hard to see left atrial dilation in cats radiographically, even on our lateral views. So radiographs are very insensitive with cats with mild and moderate disease. So that can make it challenging. And then NT-proBNP is a good blood test. It's pretty sensitive and pretty specific, about 85% sensitive and 92% specific if you look at various cutoffs, but it's still not a perfect test. And so if we do an NT-proBNP on every single cat that walks in our clinic, we're going to find false positives and we're going to have cats that we don't catch HCM on. So it's hard to diagnose. And then there's a misconception that if a cat does have HCM, that they're all going to die. And that's just not true. So not all cats with HCM actually go on to develop clinical heart disease and make it obvious that something's wrong. And so there was a really good study that was published in 2018 called the Reveal study. And it looked at the course of over 1,000 cats with hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy and followed them over the course of their lives to see what their risk for developing one of these 3 heart outcomes. So either congestive heart failure, arterial thromboembolism, or sudden cardiac death. And what they found is if you're a cat with HCM, you have about a 30% chance of one of those 3 things happening to you over the course of your life. So I guess the optimist viewpoint would be there's a 70% chance that nothing's going to happen heart-wise, which would be great. But if you look at the specific outcomes, about 23% of the cats with HCM did develop congestive heart failure. 11% developed an arterial thromboembolic event, 1 or more, and about 3% had sudden death. So for our next slide, and this one's supposed to be interactive, so should there be a QR code, Heidi? Okay. Sure. Here we go. Yay. Okay, good. All right. So I would like to know how much, if you're aware, how much does your practice charge the client to run an NT-proBNP in a cat with suspected heart disease? And while you guys are answering, I don't run a lot of these myself because I have the benefit of having an echocardiography machine in my exam room. So I can find out in real time if there's heart disease or not. So I haven't admittedly run this test myself in at least a few years. And I was visiting a clinic a few weeks ago, and I was shocked at how much the price has gone up, just because the cost of laboratory medicine to that clinic has just skyrocketed, unfortunately, in recent years. And that's not our fault. But I was really surprised how much it cost. Okay, so we have 6 people responding. The majority are saying less than 100. And then the rest are saying 150 to 200. Okay, that's better than I heard the other week. I heard something close to $250 and I was shocked because it's a screening test. So that made me sad that IDEXX was charging that much for a screening test for heart disease. So, Okay, thank you for responding. All right, so current treatment for HCM. We don't have anything where like, yeah, you absolutely have to do this, this works, you know, this is where we need to go with this. But what we often do, if there's any kind of left atrial dilation or spontaneous echo contrast, which would be that pre-clot formation on echo, we will prescribe an antiplatelet drug called clopidogrel or Plavix, the quarter tablet once a day. And we're trying to prevent arterial thromboembolism. If that drug alone is not effective, then we can also add in rivaroxaban or apixaban, and those are anti-factor Xa medications. And then I also have up here atenolol and diltiazem, which are becoming a little bit more old school. So back in 2006, when I started my residency, it seemed like the East Coast prescribed beta blockers and the West Coast prescribed diltiazem, which is a calcium channel blocker. And people were in a hot debate about which one's better. And it turns out that neither one really works. So it's kind of unfortunate. But the rationale for prescribing atenolol would be that it slows the heart rate down. And that's important for cats with diastolic heart disease because their heart can't relax well during diastole. So if we give them more time for diastolic filling, then they can have more filling and thus more cardiac output. The other reason atenolol theoretically could be helpful is if you remember back to that school, about half of the cats with HCM have an obstructive form of the heart disease. And so that means that their mitral valve is inappropriately not staying closed in systole when it should be closed, and it's kind of flipping up into the left ventricular outflow tract and causing an obstruction to blood flow leaving the heart. And so when that happens, the left ventricle has to work even harder and pump even harder to get blood to leave the heart. And then those cats have pretty loud heart murmurs. There's a lot of turbulence in the left ventricular outflow tract. And those typically tend to be the cats that are diagnosed first because they have these loud heart murmurs saying, hey, something's wrong, you know, do further testing. And so atenolol, by decreasing the contractility of the left ventricle, actually will help the mitral valve to stay put where it should be during systole. And cats with HCM actually are hypercontractile. So their hearts are pumping very hard. And it's totally okay to decrease the contractility a little bit because they can afford to lose that. And so atenolol, by being a negative inotrope and a heart rate slowing medication, can be helpful to cats with HOCM. So we thought. It turns out when you look at studies that evaluate this in a retrospective manner, that there really isn't much survival benefit to cats that get atenolol. So some of the novel therapies that they're using in humans would be these myosin inhibiting compounds like mavacamten and aficamten. They're incredibly expensive. They're not available to even academic cardiologists for a chronic long-term using. So unfortunately, they're just not available to us right now. But mavacamten is approved for HOCM in humans. So maybe with time, it'll become less expensive and more available, but not right now. So that leaves us with rapamycin. So what is rapamycin? I had not even heard of this drug 2 years ago. So in 1964, there was a Canadian scientific expedition to this really remote island in the South Pacific called Rapa Nui, which is also called Easter Island. And their primary goal, I believe, was to actually study the human population on this island. And they were thinking it would be kind of a homogeneous population where people all shared the same DNA, same genetics. And it turned out that was a false assumption because there actually had been some movement to the island, unfortunately, through slavery. So the population was more heterogeneous than they thought. But they also, while they were there, knew that there was some very rich soil on the island, unlike other places around there. There was something really special about the soil. It was really fertile. And so they collected soil samples from various locations and brought them back to Canada and analyzed them over the next 2 decades. While they did that, they isolated a new strain of bacteria called Streptomyces hygroscopicus from the soil. And they extracted rapamycin from that. And it was a macrolide-like compound. So it had antibiotic properties. And they continued to study it for the next several decades. So rapamycin was named after the island's native name, Rapa Nui. The initial findings was that it was also a potent antifungal agent. So not just antibiotic, but antifungal. And it's a serine kinase inhibitor. So it's very important with a bunch of enzymatic processes that happen inside the cell. The first use they found is it's very immunosuppressive. And so that led to use in humans. And so humans getting organ transplants, I think the first one they looked at it in was kidney transplants, we all know that we want to immunosuppress that population so they don't reject the transplant. And so for humans who couldn't receive more traditional medications like cyclosporine or tacrolimus, maybe because of side effects, renotoxicity, things like that, they tried rapamycin as an immunosuppressive, and it was very effective for that. Some people now call rapamycin sirolimus, so I put that up here on the slide because there's lots of names for this drug now. But they found out that rapamycin is involved with this mTOR pathway, which I will briefly discuss. And mTOR stands for mechanistic target of rapamycin. Used to be called mammalian target of rapamycin, but has now been renamed to mechanistic target of rapamycin. The mTOR pathway plays a role in cell growth and protein synthesis, to put it briefly. It's a giant diagram. We don't actually know everything there is to know about this pathway, and researchers are still studying it. But we do know that the mTOR pathway is involved with autophagy, or autophagy, as some of my colleagues say. They'll say it with a British accent, like autophagy, and they sound very professional and very formal. So what is autophagy or autophagy? It's basically the process of cell turnover. And so when we're a cell, we have our waste products, and we need to secrete them. So the cells will do that, and they'll package up in little lysosomes and get rid of the cellular debris from the cell. And so that cell turnover is autophagy. And it's very affected by the mTOR pathway. Rapamycin inhibits the mTOR pathway. So it blocks the activity of the mTOR pathway. And we'll also talk about that a little bit more in a second. So it kind of stops this cell growth and cell protein synthesis pathway. In kidney transplant patients, as they started to use this medication, they found out that patients receiving rapamycin had reduced left ventricular hypertrophy, even when their blood pressure was well controlled. And I put that in there because we all know that having systemic hypertension causes you to thicken your left ventricle, right? Because you're pumping against increased afterload. And so you could say, well, of course they had LV hypertrophy and it got better, but that's because you were treating their high blood pressure. But when they excluded that and said, no, these patients actually had normal blood pressure, their left ventricles were still reducing in thickness. So in preclinical studies in humans, they found that rapamycin decreases age-related cardiac inflammation, fibrosis, which is scar tissue formation, hypertrophy, and systolic dysfunction. So now you can see people saying, oh, well, let's go study it with DCM, with dilated cardiomyopathy, because maybe it'll be helpful with dilated cardiomyopathy too. Rapamycin reduces pulmonary vascular resistance and pulmonary arterial pressure. So it can be helpful, perhaps, with the treatment of pulmonary hypertension. In animal studies, so specifically mice, they looked at pressure overload models by banding the aorta on the mice aortas. So that caused a dramatic rapid increase in pressure in the left ventricle. And rapamycin either prevented the thickening of the myocardium when the band was placed, or if they allowed the band to be there for several weeks and they allowed the mice to develop left ventricular hypertrophy, and then they started rapamycin, it would reverse the hypertrophy. So there's two kind of sub-pathways with mTOR. There's mTORC1, mTORC2. They found out that the mTORC1 pathway is very sensitive to rapamycin and is easily inhibited by this drug. The mTORC2 pathway is less sensitive. So you actually have to give pretty high doses of rapamycin to inhibit the mTORC2 pathway. And those are the doses associated with immunosuppression. And when you're giving humans high doses of rapamycin, like for organ transplant rejection and now for cancer treatment, there are a whole list of pretty notable adverse effects. So this is not just a benign drug. Humans have developed infections, including severe pneumonia that has been fatal, mouth ulcers, headaches, fevers, hypertension, nausea, pain, UTIs, peripheral edema. There's a whole list here. I'm going to highlight glucose intolerance. So this is a very tricky drug to give in diabetics or pre-diabetics because it does lead to glucose intolerance. It can cause hypercholesterolemia, hypertriglyceridemia, and increased creatinine. So at low doses, when I say low doses, they found that the mTORC1 pathway, which is where the low doses inhibit, you actually only have to kind of do pulse therapy. So once a week dosing. So not only are you giving a low dose, but you're not doing it frequently. You're doing it about once per week. Low doses have been associated with anti-aging effects. So that's kind of all the rage right now in human medicine. Is how can we prevent aging? And there's even a pretty large study in dogs being done at Texas A&M and the University of Washington looking at the effect of rapamycin in aging in dogs. It's also effective for neurodegenerative diseases and, of course, cardiac indications. So the big question. In HCM, we know that we have maladaptive hypertrophy. We have these left ventricular walls that just keep thickening and keep growing. If we can normalize this hypertrophy or even reverse it, how can we change the course for HCM in cats? So enter the RAPACAT trial. So this came out it was published in July of 2023, so not quite 2 years ago. And this study was performed at 2 institutions, at NC State and UC Davis. So let's talk about this study because it was really, really transformative for feline veterinary cardiology. This was a multi-center prospective study. So this is the kind of study you want to see. It was randomized, double-blinded, and placebo-controlled. So the 2 sites again were UC Davis and NC State, so kind of bicoastal. And they included cats with clear subclinical HCM. So these were not borderline affected cats. These cats definitely had HCM. They had thick left ventricular walls, but they were subclinical. So they were not in heart failure. So we're talking about stage B1 with no left atrial enlargement or stage B2 with left atrial enlargement. The cats were divided randomly into 3 treatment groups: placebo, low-dose rapamycin, which was defined as 0.3 mg per kg once a week. And this is a delayed release formulation. That's what the DR is. So the delayed release is better for absorption. And the high-dose rapamycin was 0.6 mg per kg, delayed release once a week. They came up with these doses through previous pharmacokinetic and pharmacodynamic studies and were able to demonstrate that these are the doses that are best absorbed. So 43 cats in total were recruited. There was about 10 to 12 cats in each study group, each of the 3 groups by the end of the trial, which was 6 months later. And again, all cats were stage B1 or B2, so no heart failure cats. Cats were excluded if they had pretty severe concurrent metabolic disease. They could not have hyperthyroidism, and they couldn't have any other medical illnesses that require concurrent therapy. So I'm going to say here, rapamycin is a medication that is metabolized by the cytochrome P450 enzyme. So there are tons of drug interactions with this drug. And it's also P-glycoprotein sensitive as well. So there's a whole host of drug interactions you have to consider. Cats were also excluded if they had a behavioral temperament that did not allow for multiple echoes every few months. They couldn't have any arrhythmias that required antiarrhythmic therapy. And of course, no cardiac symptoms, no creatinine greater than 2.1, no hypertension. And interestingly, the study investigators did exclude cats with severe HOCM. So that LVOTO, these are cats with left ventricular outflow tract obstructions. So we were talking about sometimes that mitral valve flips up into the outflow tract. So if they had a moderate or severe obstruction, the HOCM cats were excluded from this study. So our general practitioners were super helpful. Most of the cats were identified by elevated NT-proBNP levels, because again, most of these cats don't have murmurs, no gallops. So a treatment effect was determined if the maximum left ventricular wall changed by greater than 0.5 millimeter. That was considered a significant treatment effect. And so specifically, the 2 walls, the interventricular septum and the left ventricular posterior wall, were measured both on M mode and 2D. And they said, okay, which one is the highest? Like, what's the highest value here? And they called that the maximum wall thickness. And so the highest value they obtained for each individual cat was taken. And then by the end of the study, if there was a change in the highest maximal wall thickness by 0.5 millimeter or more, that was a treatment effect. So again, 43 cats started the study. 2 months into it, we were down to 41 cats. And then we had 38 cats by day 120, or 4 months. And then finally, at the end of the study, 6 months later, 36 cats had completed the study. A few of these 7 cats that were lost during the study were lost to, one was lost to follow-up, One had an owner who just had some life circumstances that prevented her from, or him or her, from completing the study. But there were some actually significant adverse effects in some of the other cats that prevented them from all completing. So one of them, not such a horrible effect. One cat just needed to start clopidogrel, so probably had developed left atrial dilation or spontaneous echo contrast. So that one was pulled, and that cat was in the placebo group. So it's just a natural progression of heart disease. But the other ones here are pretty noteworthy. So one cat in the low dose rapamycin group did develop, and he had not been diabetic before. He did develop a diabetic ketoacidosis and died. Like they tried to treat and he still succumbed to the disease. So again, kind of some concern there that rapamycin might not be the best choice for a cat that is, this cat was at risk for diabetes. He was very obese. So that was kind of, at least to me, very like, ooh, noteworthy. And then there was 3 cats in the high dose group that were excluded because of adverse events. So 2 of the 3 cats developed left-sided congestive heart failure. One of them was euthanized. And 1 cat developed seizures that the cause was not identified, and that led to death. Total adverse events between the groups, the placebo, the low dose, the high dose, they looked at anything. So like if you develop nausea, if you develop diarrhea, anything was an adverse event. There was not a statistical significant difference between the 3 treatment groups, even though here you're like, ooh, like there's some pretty bad stuff in the high dose group and the placebo is not that bad. So the results of the RapaCat trial, the placebo. So this is the top line on the graph. The cats did progress over the study. So in 6 months' time, which really isn't that long, their left ventricular hypertrophy worsened. In the low dose, which is the pink line on the bottom, it shows that the rapamycin halted the disease progression. So they didn't significantly get lower, but they did kind of stay the same. They were stable. And there is a significant difference, the p-value is 0.01, between the low dose group and the placebo group. Now, the question I had when I first started reading the study, was there a difference between the high dose group and the placebo group? The short answer is no. But if you pool the rapamycin together, the low dose and the high dose together, and compare against placebo, then it did reach statistical significance. And that p-value was 0.05. So the conclusion of the study, results demonstrate that delayed release rapamycin was well tolerated and may prevent or delay progressive left ventricular hypertrophy in cats with subclinical HCM. And of course, additional studies are warranted. This was only 36 cats completing the study. And this is the only study that we have. We have one study showing 36 cats over the course of 6 months. So that is literally all we know with cats with HCM. So based on the RapaCat trial results just discussed, how eager are you, if you do practice with cats as a feline practitioner, to start prescribing rapamycin? So you could say, I want to wait until this drug is fully FDA approved for cats. Or you could say, I want to wait for a larger follow-up study like this HALT trial that we're going to be talking about, evaluating clinical outcome that will also detail the adverse profile more thoroughly. Or, yeah, I'm excited about this drug. I want to start prescribing it for all of my subclinical HCM cases. What do we have to lose? Or maybe you're so excited about the drug that you want to prescribe it for every single cat with a heart murmur. And that's fine. There's no judgment. I'm just asking. So I want to see what people say. We all have different levels of aggressiveness with new drugs. Everyone's conservative in this group. I love it. All right, here we go. We have one person. They're gonna try it in a few cases. Okay, that's what I thought you guys would say. All right, good for you. So the general public does not agree with you guys. So let's go to the next slide. So the aftermath of this trial, it got published 1.5 years ago. So now with the internet's a fascinating place to me. I don't know if you guys agree, but it's just, oh boy. Okay, so websites for the general public have been launched so that the general public can obtain rapamycin. So keep in mind, rapamycin in the study, it was a specially formulated drug by a very specific company for the use of this study. It was a delayed release, and it's a proprietary formulation. So no one really knows how other forms of rapamycin work, and no one knows where people are getting these rapamycins from. So anyway, I'll go on. So this is just taken from a website. It's a screenshot. I'm going to read it in a dramatic voice. One thing is clear. Until now, the diagnosis of HCM has been a death sentence for the kitties that bring us so much joy and companionship. Now, it's not. So keep in mind, remember, 30% of cats with HCM develop a heart outcome, sudden death, ETE, heart failure. But according to this website, it's a death sentence. Very dramatic. Okay, next website. Your pet may die sooner than they should. Let's work together to change that. And then they're just going on and on here about, I think, the anti-aging effects of rapamycin, because they're saying now that, did you know, there's a simple procedure that may increase your small dog or cat's life by up to 15%. What that's based on, I don't know. Yes. So our pet longevity consults are personalized medicine for your pet. So you can schedule a longevity consult, and when you do that, you can win a free pair of sneakers. So nothing says scientific validity like a free pair of sneakers. Yeah, if Heidi, if you wanted to get vets to refer here, you could say, yeah, with every referral, you might get a free pair of sneakers. Trust us, we're good doctors. So I had fun with this. So I'm making light of it, but as a cardiologist, we are just starting to get bombarded by inquiries about this drug that is not available yet. Like, it's not even available, but maybe you guys are too. Okay, so let's talk about the HALT trial, because this will give us answers. These are the answers we want. When this trial gets published, we will have more answers. This is a much larger, multi-site, blinded, randomized, placebo-controlled clinical field study. So the objective of this study is to determine the effectiveness and the safety of 12 months dosing of once weekly rapamycin, which has now been renamed to felicin, conditional approval, that's the CA1, in feline subclinical HCM. So at the time when I was preparing this talk, they were going to conduct this study at 15 to 20 clinical sites all across the world. They're actually over 30 now, over 30 sites that are recruiting cats. And so they will aim to enroll 300 cats, and enrollment started around, I think it was around November of last year. So pretty new study. So here are the trial study sites in the United States. The closest one to us, unfortunately, is not that close. It's in Waukesha, Wisconsin. But if you guys have any clients that visit out there, excuse me, that are interested in being a part of the study, they are actively recruiting cats. I guess most tend to be bi-coastal. There's a few in the Midwest. So inclusion criteria are similar but not completely the same as the RapaCat trial. So you still have to be a stage B1 or B2 HCM cat, so no heart failure is allowed. So males are allowed, so castrated males or intact males, both are fine, but female cats do have to be spayed. And that's because the mTOR pathway does have some implications with female hormones. So they did not want to include intact female cats. Body weight is greater than 2.5 kilograms, which is a little bit more leeway than the last study. I didn't mention it, but the last study had to be a bigger cat than that. So greater than 2.5 kilograms, older than 18 months, and less than 15 years at the time of enrollment. And so now they are saying that all stage B2 cats should be receiving clopidogrel. So the cat has to be able to tolerate receiving clopidogrel once a day to be in this study if they have left atrial dilation. This was a mandated drug. So exclusion criteria, again, if they're symptomatic, sexually intact females, cats that can't take medicine once a week or once a day, any echocardiographic diagnosis that's not associated with HCM, diabetes, kidney disease stage 2 or higher, liver disease, hyperthyroidism, and because of the potential immunosuppressive properties of rapamycin, so if you have an active infection or a non-healed wound, you're not a good cat for the study. And then we have all of our drug interactions with rapamycin. So there's a whole list of medications they're not allowed to be on. And plus, they don't want cats that need these heart medications because those cats have more severe heart disease. So here's a little setup of the study. These cats are going to be echoed prior to enrollment, 6 months in and 12 months in. And these have to be pretty tolerant cats. If you look at our screening day, this cat has to go through blood pressure, an exam, an echo, 3-minute ECG, x-rays, blood, and this is for CBC, chem, thyroid, cardiac troponin I, NT-proBNP, a whole host of blood tests. So here's the protocol of the study. So they're coming in every few months. And this trial is designed to look at not just echo changes, because the Rapacat looked at echo changes, and that was it. This trial is looking also at disease outcomes. So this study is much more important to us clinically because it's going to help us answer the questions, does rapamycin have to be started before left atrial enlargement? Or is there still a benefit once left atrial enlargement occurs? So for the stage B2 cats, is it still worth it? And so I think this will be clinically helpful for us. The good news also is that the study is progressing significantly ahead of expectations. So they have been overwhelmed with cat owners being like, yes, I want to help. I want to be in the study. So they already have about 50% of the targeted 300 cats after just a few months. So that's wonderful. Completion is anticipated by 2028. So hopefully we can expect the publication in 2029. So meanwhile, about a month ago, March 14th, the FDA did conditionally approve rapamycin for the use of subclinical HCM in cats. It is not available yet, and so it will be available through the company that makes it, I believe, DACVIM, which is based in Ireland. I'm not sure how they're going to distribute it to us yet, but it will have to be prescribed by a veterinarian. So there will have to be a valid veterinary client-patient relationship. So future directions. Feline CA1 or rapamycin will only be available, like I just said, from prescription from a vet. We're going to want to pre-screen these cats for liver disease, diabetes, severe kidney disease is important too. So we have to be a bit selective on which cats get it. And the tablet sizes, interestingly, will be 0.4, 1.2 mg, and 2.4 mg. Again, with our target dose being 0.3 mg per kg once weekly. So future studies that are already in the pipeline, we're going to evaluate it in dogs with subaortic stenosis, perfect population to look at because those dogs have left ventricular hypertrophy due to pressure overload. And in dogs with DCM, there already has been one study where the results were presented at a cardiology meeting with just specialists together. The particular doses they chose didn't show much effect on DCM in dogs in that particular study. More work needs to be done, but nothing quite as exciting as the HCM in cats yet. So stay tuned. All right, so for those of you who know me, I'm a corgi person. I have to have a corgi in every talk, and this is a cat talk, so I found a slide with both. So we've got cats and corgis. Any questions? And thank you for having me. So no questions from the room. Look at Zoom. Oh, yeah, Dr. Anderson.
Genetic mutation, the main sorry, things.
Mm-hmm.
Do you know if there's what reference lab?
NC State. NC State. Yeah. Okay. And NC State's website has a good, like you can Google it and they have all the information there about mucosal swabs, and I think they're like $30. Yeah. Okay. Okay. We use BioNote for NT-proBNP, which is significantly more cost-effective than IDEX. Oh, nice. This is probably not professional, but I'm going to take a screenshot of that. Because yeah, the clinic I was talking to, thank you. The clinic I was talking to was using IDEX, and for sure their pricing has really gone up. So it sounds like BioNote has better pricing than IDEX. Thank you for that comment. Yay, corgis! I like that comment. And this is an interesting comment. Yes, for cases that are progressing rapidly, I would be more likely to offer to clients at this time with this limited information. Absolutely. Yeah, you feel like in that case, you have nothing to lose. If you watch a cat that's just progressing so quickly, it would definitely make me want to try something investigational more. I agree with you. Okay, I think that's all the questions. Thanks so much. Everyone enjoy your lunch, and I'll let Heidi
Thank
take
you.
over. Right.
I'll take your mic there too. Thanks so much.
Yeah, absolutely.
All right, everybody, we're going to take a break for lunch and let's see. Dr. Anderson, can you look at your, do you have your, can someone tell me when we resume on the agenda? I think it's 1 o'clock, but I'm not. Yeah, so we'll resume again at 1 o'clock. Thanks very much.